Good morning, everybody.
Good morning.
I said, The widow woman has well water because nobody wants to take the morning floor.
6 months.
Oh, really?
Yeah.
5 minutes.
Who was responsible for that?
Yeah, they do it.
Who ultimately came out and took care of it?
The city. Well, the city came out and they fixed it. They put her on the city water. I don't know if Dot
Ponied up too.
ponied up
And it was
too.
a well?
Yeah, they had well water.
So they had
Because
a
they were
water
in the
right,
county
the
for
state.
years.
Yeah.
And then the city came by and took part of their yard in the front to widen the road out in front of their house. And at that time, my brother says, saying, you need to compensate. So if any time I want to, I can hook up to city water. And I go, okay, if you'll let us have this property, we'll let you have city water. Well, so, I mean, he already had it in writing, but the city had to do it.
Interesting, a little bit of threat of bad publicity.
Bad publicity sure can work fast.
All right, hey, this looks like a decent group. Let's go ahead and get started. We know more people will be coming in, but we've got these 4 seats right here at the front for all the latecomers, so that's perfect. Everyone, thank you for leaving those open for the latecomers. That's great. Well, welcome. Good morning. I'm Mindy Tueller, and let's go ahead and get started. Use this and hope that we can, you can see that on GoToMeeting we have a number of people and we want to make sure they can hear us okay. All right, well, here is our agenda this morning. We're going to start with our welcome and introductions, and then we'll move on to our brainstorming period of time, and after that we'll have our main presenter, and we're really excited about this today, and that should take up the bulk of the time. So, like I mentioned, I'm Mindy Tueller, and I manage the Mental Health Portal, and I facilitate this meeting, and I think most of you know me. We do have at least one new face, so that's exciting today, but before we don't recall, that's me, not anyone else, but let's go ahead and make sure that we recognize the people who are on GoToMeeting and also on our remote connection, singular today it looks like, and we'll just ask that anyone who is on GoToMeeting to make sure that if we can't see your name for some reason, perhaps you're just calling in and not logged in via computer, if you wouldn't mind letting us know somehow who you are, whether it's through shooting me an email later. It just helps our data. We need to know who's attended and how many for grant purposes and other things. So great. So let's go ahead and, if you don't mind, Gabby, you can help us know who's on GoToMeeting.
All right, so we have Melinda Tibbles on the phone. She's a care coordinator at Utah Valley Pediatrics. Good morning, Melinda. Then we have Dr. Chuck Norlin on the phone. Chuck, can you unmute yourself and introduce yourself, please?
Hi there, this is Chuck.
Okay. I could have done that. All right, then we have Erin. Erin, you would like to introduce yourself?
She may not have.
Good morning, Erin.
Hello.
Erin's our administrative assistant. She helps out on these and takes notes. Hi, Erin. Thank you.
Gwen Anderson. Gwen, can you unmute yourself and please introduce yourself?
Hi, this is Gwen. I'm calling in from Price.
Wonderful. And what is your position?
I'm a care coordinator under Eric's team.
On Eric's team. Perfect. Kelsey? Kelsey, can you please unmute and introduce yourself?
Yeah, I'm Kelsey. I'm a care coordinator with the ISP in Blanding.
Oh, nice. Thank you. Linda? Thank you.
Hi, I'm Linda Stevenson. I'm a care coordinator with Integrated Services in Ridgefield.
Okay, great. Natalie, can you please unmute yourself?
I'm Natalie Allen. I'm the nurse practitioner for Integrated Services program.
Good. Then we have Neva Stevenson, yeah.
Hi there, this is Neva. I am the physician liaison at Shriners Hospitals for Children.
Great, thank you. Tony, can you unmute yourself, please?
Hello, this is Tony with Integrated Services.
Great, thank you. Then we have a CSHCN coordinator. Can you please introduce yourself?
Maybe not. Okay.
Maybe not. And then we have caller number 01, which I don't know who it is, but you are unmuted. Can you introduce yourself, please, who just called in? Maybe later. My name is Gabi Baragoshi, and I'm one of the QI specialists at UPIC.
I'm Dawn Bentley, also a QI specialist at UPIC, and we're also the clinical site coordinators for the Spark for Autism project too. So keep us in mind when you're working with your patients with autism.
Yes, and if you don't know what that is, see these ladies and they will tell you. Do you want to tell us who you are?
I'm Amber Willis. I'm the presenter, so you'll hear a lot from me.
Yeah. Thank you for being here.
Greg Hawks with James Mason Centers for Recovery.
Eric Christensen, Utah Department of Health Integrated Services. And who should be sitting next to me, Walt Torres, also with Integrated Services.
Cicely Tillman, Care Manager at Memorial Pediatrics.
I'm Cassie Crane. I'm a Care Coordinator at Wasatch Pediatrics South Point.
I'm Heather Castor, and Care Coordinator at Wasatch Pediatrics in Draper.
Sharon Norda, I'm a Care Coordinator with Rainbow Kids at Primary Children's.
Hi.
I'm Tiffany Lambert, and I'm the new Care Coordinator at Utah Valley Pediatrics.
Welcome. Welcome. Happy to have you here.
I'm Margie Olson. I'm the old care coordinator who is leaving, retiring next month. So
this is Margie's last time with us, so we're happy that you could come back this last time and we get to see you one more time.
I'm Pat Rowe, Pediatric Nurse Care Manager from Select Health Insurance. Boy, that didn't want to come out.
I'm Gina Polomeni from Utah Family Voices and the Utah Parent Center.
Kay Haynes with the resources on the medical home portal.
I'm Katie Green. I am a parent consultant with Utah Parent Center and the Utah EDDI program.
I'm Angie Richens. I'm the Behavioral Health and Care Manager at Alpine Pediatrics.
I'm Chloe Kirkpatrick, and I'm one of the care coordinators at University Pediatric Clinic.
Great.
I'm Becca Parker, and I'm the other care coordinator at University Pediatric.
I'm Linnea Bauer, and I'm the Services Support Manager for the Medical Home Portal.
And Wes?
I'm Wes Smith with Tri-County Health Department, also with the Integrated Service Team. I'm a care coordinator.
Great. Okay. And I fully anticipate that we'll see a few more people coming in, so it's no problem. All right. A little bit of housekeeping. I think most people know that there's at least one bathroom pretty close accessible, so it's kind of in the center of the building. If you go down this main hall, just past the fellow sitting at a little desk, it's kind of right there in the center by a kitchen, and it's please go use that whenever is necessary. We're pretty laid back around here. There's a Wi-Fi network called Blue Zone if you need guest Wi-Fi. And then, as most know, we get shut off and Wes disappears promptly at 10 o'clock, so we try and wrap up by about 9:59, a few seconds, so that we don't blip out and miss anything on our recording and with Wes. So, all right. A few announcements. I just wanted to say thanks, everybody, for the help. When Cassie put out her request, boy, everybody just came flooding to the rescue. And Cassie, without meaning to put you on the spot, do you have a little update you could give us?
I wish I had a better update. I talked to this mom on the phone and gave her like a few resources, and then I was like, let me find out if I can find anything else. And then I got like tons of answers, which was so helpful, and now I have not been able to get a hold of her again. So I have a whole list of things to tell her, and I'll just hopefully talk to her again soon. That was really helpful. I really appreciate it.
So you're ready.
I'm ready to go.
She's ready.
Yes.
Okay.
Yes.
Well, I just want to reiterate that that's really what the purpose of this group is. And so we have that listserv, which you all can post to it. You don't have to put it through me. You're welcome to, and I'm happy to do that. That's great. And if that works for you, I'm happy to be the poster. But if you just reply to the list email address rather than me individually, it goes to everybody. And then somebody else could respond same way, and it'll go to everybody. And you're welcome to do that. We just ask that you don't put out any PHI, and you are thoughtful in the way you do your posts and your responses. But that is exactly what that list is for. And it's just so cool to see it coming together. Like that. So thank you very much for everyone who responded for Cassie's case. So fingers crossed that that'll get resolved. Okay. And then the James Mason Centers for Recovery. So this is kind of timely. Hopefully everyone saw that email got sent out shortly after all the resource help emails were going back and forth. And do you want to just mention something?
Yeah, so we're just putting on an appreciation event for all the providers that we work with, and really just all the people that work with adolescents and teens. It's just a way for us to say thank you for what you do. So it's just going to be actually, our facility is just right across the street. So it's just going to be at our facility. We'll have bounce houses, face painting, music, free food. So please come and let us say thank you to you and to know you a little bit more and stuff like that, but you're welcome to bring your family or a friend, spouse, whoever. So,
and we can make sure more information goes out with the resources of the month as well. But that's, I believe, in the morning or around lunchtime, like 11 to 1, something like that. And the address is on there as well. So. Okay, and then this is something that hasn't gone out yet, but I'll make sure to send something specific out about it probably just later today. The Medical Home Portal is doing a usability evaluation, specifically on the part of our website that is designed for parents and families. So the content there that is really written specifically and directly for them. And we're working with a group at the University of Utah that's what they do. And so for about 30 minutes, in an interview that can be done in person or remotely, that helps helps us understand what parents see and experience when they get on the site and find out if it's useful or if there are things that we can do to improve. There'll be a $25 Amazon gift card for those parents. And so, of course, we're looking for parents with children with special health care needs. So if you have parents that you think fit that description who might be willing to do this for us, we would sure love it if you could help them get in touch with these evaluators. And I will send out that contact information again today with a few more details to help you feel empowered to talk to parents. But we'd really appreciate your help in trying to find some help with that evaluation. Okay, just want to let you know that we have a lot of new content or updated content on the Medical Home Portal. So we've got a number of 4 physician pages that are brand new, one on oral health, one on caring for burn injuries in children, one on treating diaper rash. We have a new newborn disorder page, so this is something now that's being looked at when a child is just newly born, spinal muscular atrophy, along with all those other screens. And then a lot of other updates of content. I even had to write more because I couldn't fit it on one page. So a lot going on there. I did mention, I think, in April and May that we were working on our autism content, and so our family frequently asked questions on autism has been updated, and we're working fast to get a number of other pages, including our big module on autism updated, waiting on a guideline, a practice guideline to be updated or to be published before we can do that.
Mindy?
Yeah.
I just found out yesterday there's a new gene therapy available for babies under the age of 2 years for SMA, type 1, type 2. It's supposed to be curative. So that is huge compared to Spinraza. That's just it improves their quality of life, but it doesn't, it doesn't cure it. But this other one, and I can't pronounce it until I look at all the letters, but it's a virus they're injecting into these babies. They're infusing into these babies. They've done a cost analysis, and it was mind-boggling for me. I don't know, Dawn, you're shaking your head. So about $1.2 million per dose. But it is supposed to be curative, and when they made the agreement, or when they did the cost analysis and the this and the whatevers, in speaking with our pharmacist yesterday, who's kind of been in the know on this, one, Select Health hasn't approved the drug, and they've contracted, so it is a covered, at least partially covered benefit, and I suspect that other families should be looking at their insurance as well to help them with that. I could not have done a $1.2 million per single infusion, and so that's also caused some controversy. But for the many years I've seen children with SMA that don't live beyond a year, and this is supposed to be curative.
I don't know if Chuck wants to weigh in, but I feel confident that we are aware of that and are updating our SMA content with regards to that. I don't have the details, but I've been hearing things like that in our clinical content discussion. So yeah, it is exciting.
Awesome.
That is true. But if I heard you correctly, you said 2 years. It's actually 2 weeks of age.
2 weeks
is when it's that's the goal, is to get kids treated by 2 weeks of age.
Oh, the pharmacist told me 2 years, so it might have been.
Newborn screening is critical to identify those kids very early. So they can get in to get the treatment. The longer you wait, the less effective it is.
Okay. All right.
You just have one treatment.
It's a game changer.
One shot.
Wow. Okay. Thank you. Okay, so this is the time when we get to kind of do in person what Cassie did via the email list to talk about any difficult cases that you're encountering where you could use some brainstorming, some crowdsourcing to find resources that might help. Talk about any barriers you're experiencing with cases, with your practice, anything like that. Any ideas, any new resources. We love hearing about new resources through this group. We also love hearing about any opportunities you've had for motivational interviewing and how that's going, any quality improvement that you're working on, anything that you've seen the win from. So this is your time, and we'd love it if you would feel free to share with the group, ask the group for help, what have you. And for those on GoToMeeting, if you would like to just type into the chat box, we can read that for you if that's easier too. Maybe our presenter is going to have more time today. Before we move into our presentation, I will mention that I'm trying to do a better job of updating this page, which is our UCCCN Resources of the Month section, specifically for 2019. And so I'm trying to make sure that before the next meeting, I've got the Resources of the Month for the previous one up here. And so this is the PDF. Actually, I think what these are now are just the link to the new version of our Resources of the Month. It's a little fancified here, so I hope that you guys find those useful. We've heard anecdotally that people go back in their email looking for those Resources of the Month from 2 years ago or whatever. We don't want to make you do that. We hope that this is helpful to you. So we've got them going back to 2017, and we try and put a little brief annotation to tell you what they are, and then there's either a PDF or, in this case now, just a link to a web page where that Resources of the Month email is. So, yeah.
I actually have one question. Does anyone have a DME company or like a go-to any provider that does special, like, car seats? Special needs car seats.
Have you tried the wheelchair department at IHC?
Well, I think what we did is, this family lives in Wyoming, and we sent them to the car seat clinic at Primary Children's. They fitted them, but then they recommend a car seat but don't provide the place, and so I was trying to find somewhere that found the specific Roosevelt seat, and I think I found like one spot, but I don't think we've ever done that before.
Is it for special needs child? Or
Shriner.
Yeah, I don't know if you guys can hear me. This is Neva. Yeah. But if want to have that family contact our special needs car seat clinic. They could self-refer there, and they can be seen there, and they can determine if Shriners can assist with getting them the proper car seat.
Okay, thank you.
You're welcome.
Can that be new patients for Shriners, or do they have to be already involved in Shriners? Okay.
Our special needs car seat clinic is the one clinic at our hospital that you're not required to go through the outpatient clinic first in order to access ancillary services. If they wanted wheelchair and seating or prosthetics or other specialists, they would have to go through the outpatient clinic. But for the car seat clinic, they can call directly and self-refer.
Great.
And I believe that information is on your portal.
It is.
Okay, great.
You got it. Okay, great.
I do have one. Sorry.
Okay, all
I
right.
wasn't. So we are doing a QI project on lipid screenings right now. So I've been in charge of that a lot. So it's working good. We're doing well. But if anyone has any other pediatric providers that can do hyperlipidemia, that would be awesome, because other than Dr. Ware's office at Primary Children's, because he is booked out a long ways, and some of our kiddos that come through that have really high cholesterol, we want to get them in quicker. And I'm having a hard time finding other providers that can treat that. I was able to actually get his email, and I emailed him personally, and he did fit one of our patients in that was really high, thank goodness. But yeah, so we're trying to find other options, but I'm kind of hitting a wall, and I think our med home providers are hitting a wall as well. So if you guys know of any pediatric providers that treat that.
The cardiology department, they have a specialized clinic at
Right,
Primary Children's.
Right, that's Dr. Ware's clinic, and they're way out.
Oh, there should be. It's weird.
Yeah, they're booked clear into October right now.
That may be one of the topics for the Peds Tele-Echo in the fall.
Okay.
And stuff, and so they'll have specialists present, and Steph and I can get you connected with the person who runs that, so you can make sure that that does come a topic that you guys can know about. And the purpose of that is to educate providers so that they can do practice at the top of their license and take care of some of that specialty care as much as they can.
Okay.
In the
that would be great. Thank you.
home.
Yeah.
So I'm just looking on the Medical Home Portal Services Directory and see a lipid clinic, part of the U of U. I'm not sure if they'd be, yeah?
I know we've sent some kids to Brenton.
See, I looked into that one but I don't know what the deal was with that.
Okay.
I'm pretty sure I called them as well.
Yeah, I know I did. Really? And do you remember what they said?
I think they were a ways out too.
Oh, shoot.
I think they were a ways out. Yeah, it's getting them in quicker than 6 months down the road.
Gotcha.
Oh, it's too bad we don't have more pediatric providers that can treat those issues, because it's becoming more and more.
Okay.
Unfortunately.
We just approved a baby to be seen at the Cleveland Clinic because the specialist he needed to see at Primary Children's was 7 months booked out. So it's better for the patient and overall cheaper to send him out of state, because they could get in 3 weeks. So it's problematic. It's all over. Yeah.
So we're just hearing from our folks on GoToMeeting. They're having a little trouble hearing, but I think we're probably moving to our presenter, and I'll have you talk like I am talking right now. That's a little bit better, but yeah, we feel like this room has done a great deal in terms of our technology, but audio is always the thing that we struggle with the most in these meetings, to make sure everyone can hear. So. Okay, well, good luck with that, Heather.
Yeah, thanks.
Okay. If any light bulbs go off, we'll send that information your way.
Appreciate it.
All right. Okay. Anybody else before we move on? I don't want to take your time away.
Do they know when, for those that filled out the medically complex waiver, when the people are going to hear?
It'll probably be about another month.
Okay. Okay, I just have like 4 families that are like
I know.
calling.
I know, and I'm as anxious for them too.
Okay,
Because,
so about another month? Yeah. Thanks.
I'll just repeat that. So about the medically complex waiver applications, probably about another month before those we'll know whether those were approved or not. All right, well, let's go ahead and turn the time over to Dr. Willis. And I'm going to switch PowerPoints here. And Dr. Willis, in addition to asking you to either clip this on or hold it, whatever you feel is the most convenient, I'll just let you know that for purposes of showing this on GoToMeeting, if we put it in presenter mode, for some reason it doesn't work. I don't know why. It's something about this room and GoToMeeting and all of that. So if you
Too
don't,
much.
Yeah, it's too much. So if
It's
you don't
okay,
mind,
computer.
This is about as big as you can get it, and I know that might be a little bit distracting, but
I'm okay. Are you guys okay? With all that you handle, I imagine. All the multitasking you do.
So if you
Can
wanna
watch this and
just press those,
Yeah,
or
right.
I can advance slides.
What about
for you.
this little guy?
I
Can I move him over here?
Yeah, of course. I think it wasn't working brilliantly for me before. I want you to see if that goes. Great. Okay.
I can even use this little guy. Or not up, down. Okay, we got this. We got this. How are you guys doing today? I'm really glad that I stuck around, that I came early so that I could listen to that beginning part of what you guys do. And I'm feeling very humbled with the collective wisdom that is in this room and that is on the internet now listening to this presentation. And so I just want to say, also as a mother of 2 young children, thank you for all you do. And I am extremely appreciative of my pediatrician and all the care that goes into all the various things to help keep them healthy. And so thank you for all of your amazing work. Can you hear me okay? I'm kind of a loud talker, so usually
We can hear you okay.
they can hear me. I'm kind of one of those people with a loud voice, so usually it's not an issue, but I guess you never know. All right, so just to start off, this presentation is on levels of care in mental health, especially regarding adolescents. Although what you will find is that regarding like elementary school age children and teens, a lot of this is going to be actually pretty applicable in terms of, so I believe that there's quite a bit of crossover. I worked quite a bit with young children between like ages 4 to 12 before I came to James Mason. So if you have a couple questions regarding that, and if there might be some things that might be unique to that population, you're also welcome to ask. Although today I'm going to be focusing most of my time on youth, on adolescents. So a little up, down, not side. Okay, a little bit about me. So I'm the clinical director over at James Mason Centers for Recovery. As Greg Hawk said, we are just across the street, so it's really close by. We are a day treatment center and also offer intensive outpatient services. So how many of you are familiar with what that means? If by raise of hands, virtual hands? No, just kidding. Okay, as far as the people that we have here, that is probably about half of you, so I'm really proud of you. That's awesome. What's interesting is even therapists in the community who are general outpatient a lot of time don't have a lot of knowledge about day treatments and different levels of care. And I think that is probably because day treatment hasn't been super accessible for a lot of people, and it's becoming something that is becoming increasingly well known and increasingly researched and understood to be a very important part, a niche within treatment and mental health. And so I think you're going to be seeing a whole lot more. You'll be seeing a whole lot more of us, I know that. And then you're going to be seeing, I think, more day treatment over several years just because it's that middle area that is just needed. And we often find that we get at certain times of year more people than we can take on. And so we have to keep growing to accommodate that. So it was really interesting. We went to an IHC networking meeting, and one of the IHC representatives gave a report on the mental health needs in the state for teens and said that 80% of the teens who need mental health services are not getting it. And that was so eye-opening to me, you know, and I just thought, oh my gosh, it's not so much, you know, how much of that is just access, right? And knowing when to refer and where to refer, and how do you differentiate that? Because there's a lot of nuances amongst these levels of care. So just to let you know, that's a little bit of where I come from. In terms of day treatment and intensive outpatient, what we see a lot of kiddos, sorry, I shouldn't call them kiddos, they are teens who experience a lot of chronic suicidal ideation. Often they have a history of attempts, often a history of self-harming. They are coming from all sorts of different areas. A lot of times they're stepping down from residential. They may be stepping up from general outpatient. Most of the time they're coming to us from inpatient. So we're kind of like this catch-all that's kind of in the middle here. And so while you see that suicidal ideation and self-harming is probably the most common reason that they come, there's all sorts of diagnoses, mental health diagnoses and issues that would come along with that, right? And I'll be speaking more to that as we move forward. And prominently, we do see a lot of emerging personality disorder traits that are coming along. Some of those emerging traits are pretty strong already in some of these younger teenagers, just given their history and growing up years. We also serve several high-functioning autistic kiddos, and they seem to do really well. It was not something that we initially intended, but we just kept ending up with them and found that they respond really well to group therapy and actually become, a lot of times, our favorite clients after they've had some initial work with us. And once they start to get it, they're like, oh, and then they're just so straightforward. And that's just a lovely change sometimes from some of our other teams that can be kind of gamey and, you know, these kinds of things. So that's kind of fun. So I'd like to learn a little bit more about you. It was good to hear some of your introductions, although I will admit that in terms of medical positions, I may not have all of the knowledge there. So I hear the term care coordinator and interconnected care, and so I'm wondering, you know, if you can maybe translate that to me about what that means in terms of in what way you work with teens. And I'm guessing that a lot of you have similar kinds of positions. Some of them may be a little bit different. But could you just kind of explain to me a little bit in what capacity you would be working with families, parents, and teens that, you know, will help me as I tailor this presentation to you and your needs? Yes.
I'm a care coordinator for a pediatric office. And I call all of my emergency room visits adolescents. I see a lot of the suicidal ideation. And I just had a case recently that I had a hard time getting them into any help because they had Medicaid. Mm-hmm. He needed help really bad. And until he was arrested one more time, they would not put him in. You know, the insurances wouldn't pay and the hospitals wouldn't let him go to an inpatient therapy.
Oh, my gosh.
And Mom was beside herself because he was threatening her. And, you know, it was a really hard situation to know what to do. And I worked really hard trying to get him some help, but because he had Medicaid, no one would take him. So, I don't know. He finally ended up back in jail again, and so they finally put him in inpatient. But
sometimes they just have to escalate to a point where
it had to escalate to that point, and that was really sad that it had to get to that point.
It is really an unfortunate aspect of many of our insurance companies is that they require failed lower levels of care in order to go, even though we as folks who work with these people a lot of times know that they should just start up here and it would set them up for success if they could then just kind of trickle down after that point, you know? But a lot of times it's like, well, we want to pay for the least amount that we can, so we're going to start them here.
But if we could have gotten him into like a daycare kind of, a day
Treatment.
Treatment place. Where are you located? We're in Utah County.
We are just literally across the street. So
From here.
Yes. So we're in Taylorsville, although we have every intention to expand. So as for right now, that's
a
where
long
we
ways
are.
to go.
Yes, and I will be talking. I will be talking about some other programs that offer services. I mean, this presentation is not just about JMCR. This presentation is about levels of care, because we are best serving our youth when we know which level they're needing and when they're needing it, right? And how to help parents know how to get there, right? And so I'll be talking about programs that I'm aware of. Greg Hawks, how many of you know Greg? He's really friendly. He's a nice guy. If you're ever wondering, he has so much knowledge about the mental health resources in the state, it kind of boggles my mind a little bit. And I'll be at different conferences and people are like, I know Greg. So he really is tapped in. And he's even tapped into some of the out-of-state networks. And so if you're looking at things like that, he can help guide you in a lot of those resources. So in terms of those programs. All right. Yes.
So I do care management for pediatrics at Select Health Insurance. So my experience is I'm not qualified to help these parents or these kids with mental health illnesses, but I will work with our behavioral health team and say, hey, I've got this kid, he might have this medical problem, but he's got this behavioral problem.
So
he's
we
on
refer him
these particular medications. So I will refer them to, to the specialists that know the diagnoses and know what's needed.
And know how to
And so, and when I go to them, I'll go to them one-on-one and say, hey, I just got this kid, this is what he's dealing with, this is what I'm helping with, help me. And they'll do their assessment and decide, does he need inpatient? Can he get outpatient, whatever? Our behavioral health people have the authority to set up single case agreements with companies that are out of network, and it's because we can't meet the needs with the in-network companies. That just can't.
Yeah, we do a lot of single case agreements over at JMCR as well, so we're well familiar with that in the situation because there are so few day treatment programs. And IOP, there really aren't a whole lot of. There's more IOP than day treatment, but there's still quite a limit on those as well. So is that pretty typical, would you say, of what you all do is more of the referral services when somebody comes in, you have a case, and it's like, where can we send them to get more of those specialized services, okay? With regard to that, what would you most hope to gain? I hope that some of this information will be new for you and we'll be able to fill in gaps for you. And I'm wondering, what are some of the things, based on what you already know and maybe that piece that you're hoping to know, what are some things that you would most like to gain from today with me being here? And by the way, whatever I don't answer today, you're certainly welcome to call Greg, and he can reach out to me, or he can answer a lot of your questions if something comes up that we obviously don't get to today. But what's the biggest hope?
In our care coordination capacity, we quite frequently run into parents who are very frustrated because they've tried multiple things. And so, we've been inpatient, and it's like they're running out of options, and, here we go again, and we're not getting the results that we want. So I think this is helpful to know there's some, other types of interventions out there that parents may not know exist.
Yes,
so
I think you're right.
Good questions, sometimes from their insurance provider, and also from the list of providers to which they've been referred. Can you do this? Can you do this? Yes. What about this? And you don't know what you don't know.
Yes. I think this presentation will meet that quite nicely. Okay. Is that similar to what you're needing? Everybody else? Okay. I
think a lot of the problems that we run into is cost. It's just incredibly expensive for day treatment, and not a lot of the population that we work with. So we just don't know where to put them.
Yeah, that is certainly a factor.
Do you guys take insurance?
Yes.
Okay.
Yes.
Would you take
Medicaid? Yes, we are paneled with, make sure that I get all this right, Select Health, DMBA, PEHP, and one other, Beacon. But we work with so many different types of insurance because there are seriously only two other, actually now one, right, day treatment program that are anywhere close by. We get single case agreements all the time. And they fill up. Programs fill up as well. So it's very common for us to do single case agreements. There are also financing options for folks. So that's often how we manage that. But it is definitely a factor, you know. If you've got somebody who, for example, is on Medicaid or is low income.
You have to go through Wasatch. No other choice.
So definitely access, right? Access is an issue. Okay. Well, I'll move forward then and just really focus this. And please ask your questions as we go along. I have it at the end, but I'm certainly fine with you asking questions to just clarify things, because I imagine that your questions are going to be questions that other people have. Okay? So just to tell you about what I have put together for you, is the first part is going to be defining the levels of care. How do you know what they are, what they look like, right? And then what is the risk criteria for each level? This is so interesting to me that as I have stepped into this role of clinical director, and I've been doing very specific kinds of presentations with the community, is how little our community, mental health, even knows about these different levels of care a lot of times. I think they're increasing now. We're trying to get the word out. And so it's really a valuable thing to be able to know the nuances between how can you tell which level they need to go to. And then I'll also talk about how to refer, because there are unique aspects to each level and how they operate. And even the individual facility is going to have their own way of doing it, but I can talk to you in terms of generalities and how this process goes, because we go all over the board. And then clinical scenario, questions to ask, right? What are the things that you're going to be wanting to ask to kind of get a sense and of where they're at and what they're needing? And then clinical scenarios, and then you can kind of think about, well, what questions would I ask these folks? What would I want to know? And then where do you think we would refer them? You know, we'll kind of brainstorm some of those things. Okay? Okay. So starting off with what I consider to be the highest level of care, it's inpatient care. Inpatient care, this is probably the one I would imagine that you are most familiar with, but maybe, I'm not sure. Would that be true? That's a guess on my part. So inpatient care, it's acute, highly acute care, and it's very short term. For youth, for children and adolescents, the standard amount of time that they go is usually a week to 2 weeks. If you see somebody who goes more than 2 weeks, then you know, ooh, this was a pretty severe case. You know, a lot of times you're going to see somebody who is absolutely super suicidal or really had a lot of psychosis. If they aren't stabilizing to some extent within 2 weeks, they're either going to refer them up to residential or they're going to refer them down to day treatment, right? So that's kind of that's usually what happens. So some of the local inpatient programs you're going to see, you've got Uni has an inpatient program, we've got Salt Lake Behavioral, Wasatch Canyons, Provo Canyons Behavioral Hospital, McKay Hospital. So those are the ones that are most closest. Most closest is completely grammatically incorrect, but you all know what I mean, right? Okay. So inpatient care, what does that look like? Well, you know, they're going to go in, and it is going to be a lockdown facility. You know, they can't leave by choice once they go. And they can be pink slipped. Are you familiar? Probably familiar with that term. So it's not something that happens a lot, but occasionally if there's a situation where you have a teen who's just like, I'm going to do this thing and nobody can stop me. And, you know, there are times when they could be made to go against their will. But that doesn't happen all the time, but it does happen sometimes. And so it's a situation, what are they doing during that time? Well, they're going to be talking, they're going to be having groups all day, they're going to be doing daily therapy with an individual therapist. They're going to have people in these groups that are going to be talking about immediate, like, coping skills, very concrete, kind of like breathing, basic anxiety management, you know, stuff like this. All they're trying to do really is keep them safe through this immediate crisis, right? That's the point. But how long do you think that it takes to build up for a teen to get to the place where they have that crisis? What are some of your thoughts on that?
It's got to be weeks.
A lifetime, right? How long do you think these issues have been going on for these kiddos? So how stabilized? So when you get to a point, I mean, what are the times when they would actually accept somebody? into inpatient care. So I'm going to talk about that and then talk about what is often what the presentation is for, what's really going to help this kiddo long term stay safe, right? But some of the risk criteria for inpatient care is that basically this teen needs to be in a place where they cannot stay safe in this moment. If they have been able to stay safe for a day or two, it's often a case where if they are able to say, nah, I might have really, really strong thoughts of suicide and they come really, really hardcore, but for this moment, I think I can stay safe, typically the inpatient is going to send them home. Even though this kid in 2 hours may flip right back up and be acutely suicidal again, right? So it's one of those situations, and I mean 2 hours might be a bit of an extreme example, but it's that situation. It's right in that moment. It's that day that they're looking at, right? And so they may have had a recent suicide attempt or a very near attempt, or they may have they may be self-harming. If they've got a history of self-harming and they've been doing it for a while and it's low level, and if they've been inpatient, sometimes they don't admit them for self-harming alone, unless it's like a first time. So if it's, and I can just speak to there were times when I would send teens or youth to inpatient and they wouldn't be accepted. And what happens is it's very important to know when to send somebody to that, because the process of going into inpatient is like an 8-hour, sometimes it's a 4 to 8 hour process, especially if they're really busy, right? And it can be very discouraging if you send them to inpatient and they don't get admitted, because then they think, well, now nobody can help me. My therapist didn't know, this care coordinator didn't, nobody knew what to do. And then I went and I got home, and now I don't got nothing. And the teen might be like, phew, I dodged a bullet. But the parent is going to be like, oh my gosh, I'm so scared. What do I do, right? So that's where it's really, really important to kind of have that sense about when they are really going to be admitted. And so high assault risk, if they have just beat somebody up, or if they're making like verbal threats, like they're going to kill somebody or they're going to beat somebody up, and it's recent, right? It's that day or it's the day before, and they're still super like aggravated and distressed and highly volatile, and it's right then yes, then you're likely to get admitted for that, right? Usually what happens in those situations is the police has had to come because that kid's throwing tables, or the parent is like holding them on the floor, or those kinds of things. They might be high. They might just have had a history of trauma. There's a lot of conflict in the home, those kinds of things. The teen may be engaging in running away behaviors. Typically not even just something that's like an hour or two, but, they've been gone for like a day or two or more, right? And that, especially if they've been doing it a lot, right? And especially if they're going out and when they're running away, they're doing some kind of risk-taking behaviors, like now they're getting high, or they're going and staying with a homeless population, or they're getting on the train and driving off to who knows where. They don't even know where. They're just getting on a train. I'm really talking hypotheticals. No, I've heard of all of these scenarios, right? These are the, you'll have these teens who just want to get away, and they do that and put themselves in harm's way. So especially if they're doing those things and engaging in risk-taking behaviors, right? Sometimes if they go hang out with a friend for a little bit, it may not be as seen as risk-taking. You know what I'm saying? But if they're staying for a long period of time and they're not coming home for like a week, you know what I mean? Then that's more of a concern. So you could also get some severe disordered eating where you have real serious medical concerns. You would probably be able to speak to this very well. What I often see is you have somebody who's restricting food to the point that they're dizzy. There are medical issues that are coming up where the doctor needs to start to monitor this. There's concerns with the binge eating that is causing. So if it's causing the health concerns and it's really this immediate risk, then that's when you're looking at inpatient care. If they've overdosed, and they're currently high, then you could send them to the ER as well. But again, they are not likely to be admitted unless there is this concern that it might have been like a suicide attempt. This does surprise me. about inpatient care. Have you noticed that as far as being high and using substances, that is often not a reason for them to keep them in inpatient. I know, it kind of boggles my mind a little bit. But unless they could have died from it, if they could have died, then it's much more likely that they would actually be admitted inpatient. So I guess that's a reflection of our insurance. But I guess, there's only so much money to go around, so they have to kind of focus it somewhere. It's rough sometimes. Have you seen these kiddos who sometimes they are just really emotional labile because they have bipolar disorder and they are not regulated on their medications? So they're going up and down and up and down and up and down and up and down, right? And a lot of times you'll see them doing all sorts of risk-taking behaviors because they are going manic, depressed, mixed episode, and then they're doing these things like spending money, they're going into these exploitive relationships, they're having sex impulsively, they're doing substances, and so they're up and down. Or you get these teens who have OCD that's also not stabilized medically, and so they go into these mental loops and they just go to catastrophization, and they're suddenly suicidal in like 3 seconds because they've just gone through this OCD obsessive loop very, very quickly, right? Or they're having delusions and psychosis, and they're in a situation where they're thinking about jumping out the window because of that kind of situation to get away from the bugs, or what I mean. So if these things are the bipolar, the OCD, the psychosis, if that's so unregulated that they are at risk of very soon to be a danger to themselves, then it's likely they would be admitted inpatient then as well. I think one of the biggest things, and I tell this to parents because sometimes what will happen is that the teen will say to you, oh yeah, I can't stay safe, right? But then you send them to the ER, and what do they tell the crisis worker? What was that? I'm fine. Oh, no, I'm good. But the parent is like, oh my gosh, I see everything that's going on at home. You're going to recant that as soon as we get out of here. You're going to, and the teen's doing all this stuff, and they've hidden knives in there or razors here and there, and they're being covert, and they're being gamey, and the parent is just beside themselves, and they're staying awake all night. Have you seen parents like this? They're staying awake all night like, I'm going to sleep in your room. And I'm just like, honey, how long can you keep that up? I could stay awake one night, maybe. Yeah, well, if it's my kid, I'd stay awake. But, how long can you do that and go to work and function? And then I've had parents like, I'll do this night, and then you do the next night, and I'll do this. And I'll feel her. I'll sleep in her bed, and I'll feel her if she gets out. And I'm like, well, how are you going to sleep? How well are you going to sleep? Because you can't really sleep. And your mental health is what's going to happen to your mental health, right? So it's going to plummet, right? So that's where I tell the parent, golden ticket, okay? If you don't feel you can keep your kids safe, you need to advocate for that when you go to the ER. You need to say, this kid is totally telling you something different than what they told me, and this is what I'm seeing, and I can't keep him safe. I don't feel like I can sleep. That's one of the biggest things that I tell parents. If you are afraid that your kid is, no matter how much hypervigilance you have during the day, and if when you sleep you're afraid they're going to take off and they're going to do something, and you can't watch them 24/7, but the hospital can, that is critical, and you need to advocate for that to that inpatient worker, to the ER, to the crisis worker, and say, I adamantly feel like that they need inpatient. And if they can do that, it's much more likely that they will be admitted. And I never say that in a situation where I don't feel like it's indicated, because that's not the point. But there are times where the teen will get gamey and they will recant, and then it reinforces this gamey behavior. You know what I mean? And it puts them in a very unsafe place. So I just try to help empower the parents to be able to not feel like they have to just say, whatever that person says, just go with it. If you really strongly feel like you can't keep your teen safe, speak to that. And that has often made a difference, I think, with these guys. Okay. So any questions on the criteria for inpatient? That's probably one that you know pretty well. No? Okay. You must know this one really well. Okay. We'll move forward. So how to refer, basically, you just need to refer them to the local ER. I often refer to primary children's just because I know that they specialize in working with youth, and that's been really helpful. There have been times where I'll refer to an ER, and then I've spoken with a crisis worker who's like, we don't really know teens as well, and so we suggest primary children. So I have just opted for that just to be careful, but certainly I would think that most ERs should be able to do this. A lot of times I'll call a crisis worker ahead of time just because it's an emergency. I don't know if that's something, maybe you could kind of consult and say, hey, here's a situation. I'm wondering about this. I want to send this person. This is what is being said. If you feel like they need to go to the ER, then there's not so much that HIPAA concern, right? Because it's, at least in the mental health. Is that the case with you guys as well? If you were to call a crisis worker and say, hey, this is what's being told to me. I think I'm sending this person your way. If they recant, this is what I'm seeing. And that's been really helpful to get some of those teenagers in when I've called the crisis worker ahead of time and just give them a heads up, right, the ER social worker, so that they can recognize what's going on. Because I had a teen once who was so hopeless and he was so demotivated he couldn't even hardly speak. And I could just speak to, this is what's going on. This is a huge change for him. He's not going to be able to tell you this. But here's what's going on. And it was so reassuring because the crisis worker says, we'll take good care of him. And I was like, oh, phew, okay. You're not going to require him to say, I can't keep myself safe. If he's in there and he's shut down, he's not telling you anything, So that was just a super helpful thing. Okay. So refer to the local ER, talk to the crisis worker. Oh, I'm sure you probably know about MCOT, Uni Mobile Crisis Outreach Team. Do y'all know about that, right? Okay. As far as, this is something that I do, if I ever send a teen to the ER, the parents most typically take them. But I have had teens who will grab the wheel if they're sitting in the front seat and will literally try to kill themselves and their parents. I've had teens who, it's not me sending them, but this is actually stories that have come to me and I've heard this, okay? So we take precautions for this. But just know that teens sometimes will do that. If they're resistant to going inpatient, they'll grab the wheel if they're in the front seat. And people don't think about that. Or they'll be hitting the parent. And the parent, so that's really scary. So it's unsafe to drive. They might try to jump out of the car. So if you make a recommendation that the parent take their teen to the ER, have the teen sit in the back seat with a supportive adult with the child lock on. Okay? And that can help a lot because that way they can do some things that would reduce it. If the teen's going to get aggressive or doing all that kind of stuff, that the parent should stop the car and call 911 and have somebody come get them. But it's amazing how often they'll be on the freeway and having this going on, which, as you can imagine, is a very scary thing.
Well, if it's not much of an issue, can they have law enforcement escort them?
Yes, that's what I'm saying. You call 911, and they will often take them. They'll take them in the police car to the local ER, right? If they can at least get to the ER, right? And if the teen is really resisting, there are folks in the ER who will come and literally drag them in. Yeah. So those are just a couple things to just be aware of and to warn parents about. You'll have some teens who are just they're totally oh, I know I need to go. But if you've got these resistant teens, then that's definitely it. But even if it looks like that they seem cooperative, I still have them go in the back seat with the child lock on. Because I wouldn't want somebody to be like, yeah, I'm going to do this, and then, you know what I mean? So, okay. Any questions about that? Okay. So what happens? And I don't remember your name, who has that lovely tie. Eric. You made that statement earlier on about what do we do when we have people who are going to the inpatient over and over and over again, and clearly this is not serving. Well, and that is because it's a short-term treatment. It's only a week or two. And it goes back to my question earlier, how long does it take for these issues to arise that put them in a situation where they're ready to kill themselves? And usually these teens have been ready and thinking about killing themselves for years. And they may have had previous attempts that they've never told anybody about. Or they've been self-harming in secret for a very long time. These things do not happen in a vacuum. And this crisis has arisen out of a substantial amount of stuff that's going on, probably in their home, in their lives, that's build up and build up and build up. And a week or two in inpatient care is not going to even touch that. It's going to, well, it might barely touch it. Basically what it's doing is getting them to the point where they can be safe in the moment, right? So that's where the inpatient care is going to be trying to decide whether or not they are safe to step down or they need to step up, okay? And so we're going to talk about how they can tell which way they should go, right? So this is where we're going to talk about residential care. People can go straight to residential care if they meet the criteria. But there's a lot of times, especially with insurance, where they're going to want to see failed lower levels of care. And if they're going to be coming from inpatient, typically either they have been in inpatient for a couple weeks and they're just like, no way in tarnation am I willing to even invest in my safety whatsoever. Right? And they're realizing that it has not changed at all. Right? Then they may go straight to inpatient. Or maybe they've had multiple inpatient stays within a short amount of time. Right? So that could be an indication.
So just catering to kind of a mouth breather here, but let me just, when I ask this, so it doesn't have to be this actual attempt or this actual issue that you say, okay, we just did inpatient for the 5th time to go. If you have a history of that, then you could do residential.
Mm-hmm.
Okay.
And I'm going to go through here and talk in the risk criteria for residential in a little bit. So I think I am getting a little bit ahead of myself, but just kind of to transition. But yeah, we're going to go right there, okay? So residential, what is it? It's long-term hospitalization. Now, long-term doesn't necessarily mean a year or two. I mean, you've got places like Copper Hills that takes a lot of these out-of-state kids who are like have a lot of antisocial, really severe conduct kind of behavioral problems. But most residentials, it's more typical to be like a month to 2 months, maybe 3 months, right? So long-term is actually not hugely long-term in most cases. But it could be longer depending on the level of severity, right? So it's full-time hospitalization. This is a lockdown facility, right? You have these teens have pervasive impairments in their daily functioning. They have these chronic, ongoing safety risks that just are not getting better with lower levels of care, right? And usually the youth is resistant to treatment. They are not invested. And also another piece to consider is that the home environment is not a safe place to be. The home environment is not in a place to set those boundaries, to have the kind of stability that's going to support the youth getting better too. So sometimes you have to take them out for a bit to try to stabilize the youth enough and to give some support to the parents so they can stay safe or they can stay sober long enough to get to some of the more core issues. And you'll have teens who have so much of these secondary gains, which are getting certain things out of going to crisis. They get a lot of attention for it. They may be avoiding, if you get these teens who are making suicide threats to get out of doing their homework. And sometimes that has served them so well that they're like, what you going to make me do? You make me go to day treatment, I'm going to kill myself. I've heard that plenty of times. And I'm like, oh, well, now I know where you need to go. That's a straight way ticket up to residential. Especially if you've done like inpatient a few times. So anyway, that resistance is key. If they just don't have any investment in their safety and they are exhibiting a lot of safety risk behaviors, and inpatient is not cutting it, then you're looking at residential most of the time. Okay? So the local residential programs, you have Lifeline and Youth Care. Are you familiar with these guys? Lifeline's in North Salt Lake. Youth Care's in Draper. If you have any questions about this, Greg is the person to ask. He will hook you up with all sorts of information. He's a guru in this. So Youth Care's in Draper. Lifeline's in North Salt Lake. Provo Canyon School is in Provo. New Beginnings. Oh, where's New Beginnings? It's West Jordan. Thank you. Center for Change. They have a few different centers. They actually have one here in Salt Lake, and they have one in Orem. They have different levels of care in different places, and I think the residential one is in Orem, right? But they have a day treatment, I think, here. But that is eating disorder specific, okay? And then New Haven is just for girls only. Is that in Saratoga Springs?
Spanish Fork.
They have,
Spanish
a couple,
Fork.
they have a couple of buildings.
Okay.
One's in Saratoga.
Copper Hills just started taking local clients, which is different. They used to only take out of state. This is a very new move for them, just FYI. Okay? Okay, so what's the risk criteria? I better move forward a little bit faster. Risk criteria for residential. It's that chronic suicide risk and self-harming risk with low investment in recovery. They're not willing to really go, they're not going to therapy. Or they're going to therapy and they're saying fluff. Or they're denying all their symptoms. They're doing all this risk behavior. And the parent's like, because the kid's like, I'm fine. I don't need any help. And you're like, are you kidding me? There's all these behaviors that are going on and you're just denying it. But that's like a power control thing, right? If I just deny it, what you going to do? Send you to residential. And a lot of parents are worried about residential because they feel like it's so strict. And so a lot of times you have parents who just are afraid. They're very rescuing of these teens. And that's part of why the teen has learned that being defiant works, because they can bully their parents into doing these things and get out of these consequences. And that's why it's gone to this extreme. You know, if parents a lot of times have been setting these boundaries and teaching their kid all this time, they don't often realize they need to go to these extremes. But then, so you get a lot of times these parents who are like, well, I don't want to take them to residential. So the kid's like just escalating and escalating and escalating. You know what I mean? And so that's a lot of times what you see. We've already talked about multiple recent inpatient stays. It's different when the inpatient stay is like a year ago. You know what I mean? We're talking like several inpatient stays within the last 3 to 6 months. Yeah. I would say even 3 within the last 4 months would be quite a bit. It's suggesting that there's really some serious concerns. Severe eating disorder needing long-term medical supervision, right? So, and I'll talk about how that's different and how that looks in day treatment versus residential when I get to day treatment. That chronic psychosis that's not stabilizing lower levels of care, right? There is a possibility that they might do something at night, because day treatment's during the day. So if there's stuff, you know, in day treatment they're here only during the day and then they go home. And if they're going to be unsafe while they're at home, then that's where we might have to refer them up to residential, right? Let's see. Oh, sometimes teens will have these really chronic compulsions or these bizarre rituals that they do that are a real safety concern. One person that we had OCD, and he would cut so much he was constantly bleeding. Bleed. And so we would put Band-Aids on him, but there was this blood issue. It was turning into a health concern, right? That it wasn't safe for us. We didn't have a full-time medical staff in day treatment. And so it was like, oh, we can't keep this kid safe. I mean, he's not suicidal, but the level of self-harming, because it's compulsive, is causing a health concern through body fluids to our other teens. Also, there have been situations where, maybe the teen might be urinating in a corner or defecating, or things like that. We had one teen who was constantly peeing his pants. And it's like, even then it turns into a bit of a health concern if it becomes extreme enough, right? And the same teen who was scratching himself, almost stabbed himself in the eye with a pencil, So, it's one of those things that, like, most of the time they're fine. And it was amazing talking with the mom, because I was like, he almost stabbed himself in the eye with a pencil. We really think he should go to residential for just a little while so he can get stabilized enough on his medications. It might take longer than the 2 weeks for inpatient. He had just come from inpatient to us. And, and he also wanted to stab himself in the hand with the pencil as well. So we're like taking away the pencil. But, they can get creative. They start getting creative as what they can find. We're like, Mom, he really needs to go to residential. And then a lot of times there's that fear of like, oh my gosh, residential, too much. But so that's where it's important to like really understand the risks and be able to explain that. And if you don't feel like you're in a position to do that, again, it's like you said, and I can't, what was your name? Back behind you, sorry. You were talking about just referring them to behavioral health and like they do the assessment, right? I couldn't see your signs. Okay, Pat Rowe. You said I just need to know who to send them to do that assessment. right? Because then they can make that recommendation. And there are times when sometimes I have to be very firm with parents about risks and what's going to happen if they don't. And sometimes they're like, well, this kid needs to, they have scout camp coming up, or they have a football camp, or they want to go to this youth activity, or we've got this vacation, and we really want to, and it's like, okay. Or they really like this class. They like, they want to do, they're doing this drama. They're doing this play at school. And it's like, you know what? These are so great. But if your kid dies, they won't be able to do that ever. And I sometimes have to really break it down to parents to help them put things into perspective about investing in their kid now and recognizing the level of risk. So regular use of hardcore drugs, this is where, at JMCR, day treatment, we'll take like marijuana users, they could have substance use, active substance use disorders and marijuana, smoking, like vaping, maybe some alcohol use. But if they have an active substance use and anything harder than that, we refer them straight up to residential. Because the level of covert behavior, the things that they're doing, it is very difficult to manage at a day treatment level. And you'll see that pretty much across the board. If they're accessing drugs through the internet and they're selling drugs and they're, because once you start to get up into these harder core drugs, they need a period of sobriety where they really just don't have access to get them into a place where they can even consider the benefits of a substance-free lifestyle. So that's why we look at those hardcore drugs. So that they could be experimenting at a day treatment level with some of these things, but if it's really regular use, then it's straight up to residential. Most residential programs will take them straight away, especially if they're using those things regularly. Because if they're using those things regularly, you're going to see all sorts of other things that are going on in their life that are typically also concerning risk-taking behaviors. And usually, how many of these kiddos who are regularly using active substance use disorders with like opiates or LSD, hallucinogens, how willing are they going to be to participate in treatment? Hardly ever. So you just know that is a straight ticket to residential. They don't have to fail lower levels of care. They can just go straight up there. If they're like, I'm not going to do I'm not even going to try this, I'm not going to do anything, okay, just go straight there. Or they could just be regularly using that stuff and they just go straight there. Repeated running away. They're just going and all the time running away, right? That's when serious conduct, antisocial behaviors, they're beating people up. It's like really serious. They've used weapons. Gang activity, if they are regularly involved in a gang, what they're being exposed to, the level of antisocial thought and propaganda, I mean, those kids who've been in gangs really can be quite volatile. And so you're looking at somebody a lot of times, not all the times, but a lot of times going on this antisocial track if you hear that there's gang activity. You don't make that assumption, but it is a common association. Okay? Sexual predatory behaviors, and then if it's a sexual predatory behavior, you're going to need probably a specialized program to work with that because that's a special licensing issue. Okay? Not succeeding lower levels of care. Okay? So the best practice for residential, how to refer, is to have them evaluated by inpatient. So if they go inpatient, a lot of times they'll be asking that question, like I said, and then a lot of residential programs will require an inpatient referral. Then there's certain tests they have to do, and they just send them straight there. A lot of times, if we had them in day treatment and we send them to inpatient, and we're like, they've been inpatient twice, we're really concerned about this and that, we can say, we'll send you to inpatient, and we're making the recommendation for residential. And they'll listen to that a lot of times. So that often makes a difference. Or sometimes people will come to us just for an assessment, and then I do all that criteria, and I'm like, I think residential. And then the insurance will look at that and say, yeah, the day treatment referred residential, we're cool with that. And sometimes the insurance will say, no, we feel like you need to at least try day treatment before we do residential. So sometimes there's a little bit of back and forth there. Most of the time they accept. I've been in this long enough that I know when to refer up. And so usually when I refer up, I don't usually have too many problems with that. Let's see. So then have parents contact the insurance company to see which programs are in network, right? And if you're wondering which ones are, you're wondering, maybe there's a special thing that I'm looking at. Maybe Greg might help me out with this. You can always call him. He'll give you some ideas and just give you some initial pointers, right? And then some medically complicated cases, like we've had situations with diabetes. That is a very tricky one to treat in day treatment, especially when we had one who had borderline traits and was constantly being suicidal. We didn't have full-time medical staff, and I was like, how much insulin does he need to take and when? And he's not taking, he's refusing to take it. And then it is amazing how even residential programs won't take kids with diabetes. Like we had to send this kid out of state, and just because he had diabetes. Because there were, and I thought, well, residential programs, they're a hospital, right? They could have a medical staff, and that is not necessarily the case. So sometimes that gets a little tricky. We also have had a situation of like eating disorders like that. Also for a lot of residential programs, they won't do it. So you have to go. And then like the Centers for Change does take eating disorders, but I think there's one that is only girls, and it has to be within this age limit, and they don't take transgender clients. So then we had a transgender client with a very serious eating disorder, and we had to send him out of state. So that's just something to know, is that sometimes you get these complicated cases that are requiring non-local treatment. Okay? Any questions on that?
The last line on that screen, it was busy times of the year.
Oh, yes.
Frankly, I think, just based on my limited experience, every day is a busy time of the year. But
Yeah.
what do you guys consider busy times?
Well, the busiest time would be between like January through April. It gets a little bit insane during those times where even the inpatient programs get full. And so you have people who should have been admitted inpatient, but they don't have the beds. And then they send them to us, and we're like, okay, what can we do to keep this kid safe? And then you're just having literally like parents doing shifts until a bed opens. I mean, sometimes. So, yeah. So probably January to April is the busiest time, and maybe between like October and November. So what happens is a lot of these things are around the school year, right? You have people who, when they first get into the school year, have had a lot of these issues underlying, right? And then they have to start school. People are all hopeful that maybe this new year will be different. And then they go to school, and they're having this honeymoon experience just getting started. And it takes them a few weeks. And then the crises hit in October and November, right? And then they go to Christmas break, and then everything's fine. And then they come back, and school starts, and they're like, ugh, I loved Christmas. I got 2 weeks off, and now all these crises hit as I have to go back to school, or, So the school, a lot of times, is a catalyst to trigger a lot of the issues that were already underlying. And so in summer, you're not seeing as many of that as a general rule, just because the parents are going on vacation. There's not all those pressures that are also causing a lot of the parent-child conflict, because the parents aren't trying to get the kid to have to do all the homework, and you know what I mean? So those are typical. But yeah, so that is definitely a piece, is that sometimes they get on these wait lists, and between January to April, they can be quite significant. And that can be it can be quite challenging to make sure that this person is staying safe enough until we can get them into residential. And so there are things that we do to try to help. If we see somebody who might be on that residential track, we warn the parent early, and we'll get them on a wait list, and we'll say, unless they redirect, that's where we're going to send them, and they have this much time to redirect, or you know what I mean? Because otherwise they wouldn't have treatment, and they're unsafe to stay by themselves. So it gets tricky. It gets tricky. And sometimes we've kept them when we've been a little bit like, okay, and we just keep sending them to the ER. And they've had to go to the ER several times until a place could open in residential, because there's just frankly nothing else. So that can happen. Any questions on that? Oh my goodness, so much to talk about. Okay, day treatment. So partial hospitalization is another term for day treatment. It's considered partial hospitalization because it's during the day and they go home at night. There is intensive mental health treatment. They've got groups all day. They get individual and family therapy. We have a part-time medication provider. And during the school year, we, as well as many day treatment programs, will have a school component where they do some school for a few hours. Like we do like 2.5 hours in the morning, right? And so, like I said, most of the time we're getting youth who are stepping down from inpatient care, and all these issues that have been chronic issues that led to them going inpatient, we're able to start, we have this heightened level of they are supervised the whole time that they're there, and they're getting all this intensive treatment, and we can really start to break through a lot of these barriers that have kept them from getting better at general outpatient, right? We also are used to dealing with kids who are on this higher level of acuity, and so we recognize things faster. We recognize bipolar, we recognize OCD, we recognize autism, we recognize schizoaffective. And we see this stuff right from the get-go because we see it all the time. And a lot of times, GOP therapists won't because they only got them for 1 hour and they're not seeing them all day. And maybe they don't specialize in that, So a lot of times we'll catch things faster and we'll get them off to do a psych eval. We have a good South Point counseling. We refer them over to South Point counseling if there's a psychological evaluation to rule out autism or to rule out schizoaffective or whatever those things, a cognitive disorder, a delay, or something like that we feel like has been getting in their way and keeping them in this chronically crisis state, right? So the typical duration for day treatment is about 5 to 6 weeks. It can be more or less based on a lot of factors. That can have to do with insurance. Insurance standard is usually about 5 weeks, but some insurance programs or companies like UHC and Aetna have been giving us fewer times recently. Sometimes only like 4 weeks. And sometimes we have to squeeze and squeeze to get a little bit more time. But it can be longer. Select Health is awesome. They are amazing. So they will typically take our recommendation, and we have been able to do so much good care within that time. So local PHP programs, we've got us, JMCR. We've got the Uni Teen Scope program. Wasatch Canyons has a day treatment program, and Lifeline has a day treatment program. Lifeline's really great for those kids with like conduct issues and substance use. So they are a little bit more strict. Their emphasis was residential. Most of the time they just step their kids down from residential to day treatment. But they do take people from just the community into day treatment if they meet the criteria. So, okay. Criteria for day treatment. Those are all these diagnoses that I said. These are the ones that accompany the chronic SI, the chronic SH, these kind of risk-taking behaviors. It's the severe depression, with the psychosis, the severe anxiety, the OCD, they're staying home all day long. They're not able to go to school. Complex PTSD, bipolar disorder. The ADHD is so bad. They're super impulsive. They can't do anything but play video games, that kind of stuff. They're failing their classes. They are being bullied at school, and now they're having panic attacks every day. They're having these ongoing suicidal thoughts that just kind of come and go. They go between periods of, I'm going to be safe, and they could be acute, where they might not be safe, and they might be safe, and then they might not be safe. So this is where it gives us a chance to do that more long-term work. For the moment, they're willing to follow a safety plan, but you worry that they won't be able to keep it. That's kind of the main criteria that I look at with day treatment. We do take kids who have some history of mild aggression, unless they could have more serious aggression if they've been to residential and they've shown that there's a low risk of them acting out physically. We can do hands-on, but we don't do very much of that. So there has to be a pretty low risk that they're going to actually do that. Sometimes you'll have kids who are acting out physically at home, but nowhere else. So as long as we can keep it safe enough at home, unless that kid starts to pull a knife on their sister, and maybe some hitting at home, but it's not to the point where there's major injuries and the family can deal with it until we get them stabilized, they can still do day treatment. Does that make sense? Yeah? Okay. Really high-risk behaviors, current substance abuse with low-level drugs. I talked about that. Mild to moderate psychosis, where they can still be redirectable and stay relatively safe, but just need a lot more intensive supervision. Low flight risk, because we're not a lockdown facility. If they run from our facility, that's usually an indication that most likely they will go to residential. Okay? So how you get them referred over here, you may consult with our admission staff at any time if you wonder, right? Because it's that mid-level and the nuances are very important. just talk with Greg or talk with me. We'll make sure that you are clear on that. Parents just needed to contact insurance to know who's in network. And then the parents can look us up or look up the program online. A lot of times they can do a tour and see what they feel best about and then do an assessment at that agency, right? And as I mentioned before, we do often do single case agreements. Okay? Any questions on day treatment?
Just wondering what the hours are like for working parents if it goes until...
Yes, I can speak to our hours. I'm sure others have different, but as far as our hours, we have different summer schedule and school schedule. So during the school year, it's 8:30 to 4:30, and they do 2.5 hours of school in the morning, and then the rest is groups and then and all the clinical stuff. And that's day treatment. And then in the summer, it's 8:30 to 3 because we don't have the school component. We just got to shift everything down. Okay?
That's actually pretty similar across most day treatment programs. It's usually around like 8:30 until about 4:30, somewhere around there.
And your intensive outpatient is like 4 to 6:30
It's 3
or
to
7?
6.
Or 3 to 6.
And well, that's the school year. It's 3 to 6 in the school year from September to May. So that they can, the idea is that they can go into school during the day and then come to us kind of like an after school kind of thing. And then in the summer, it's 8:30 to 11:30 so that they can go and get a job and go on and do all that stuff, right? Gosh, time went by fast. Any other questions on day treatment? Okay. How well do you guys know IOP? Do you want me to speak more to this or do you just want to ask questions? What would you prefer? Because I got 5 minutes. Anybody?
Actually, I think this is probably
our we've got like 2 times? Okay. So I think the main thing to just know, and you can read this, and again, consult. That's probably the best way to know. IOP is mainly the idea that they can pretty much succeed well enough in school. They're benefiting from school. We want to keep them in school. And during the summer, maybe they've got a job that's really helpful or really supportive, that's really healthy for them. But they do have some of these risk factors, these safety factors that are concerning. They are not succeeding in general outpatient. It's not doing enough to deter the depression or the anxiety, or there's some piece here that they aren't sure of. They're wondering about bipolar, they're wondering about OCD, they're wondering about, autism. And so it can be helpful for them to get into group therapy, get a lot more intensive help. You know what I mean? So it's 4 days a week, Monday through Thursday, about 3 hours a day, right? So that's kind of the benefit of IOP in a nutshell. The referral process is very similar to what you would see for day treatment. Okay. All right. Well, are there any last questions?
Can I just ask a general on insurances?
Yes.
I have PEHP. I've never had to use this type of a benefit before, so I have no idea what the standard across, the industry is for what a commercial insurance will pay for along these lines, and what are the limits? What's the time frame? Are they usually covering it at like an 80-20 sort of a thing? How a lot of times do these?
I'm going to defer to Greg for that.
So usually, like it's usually standard. Like you would meet your deductible if it's in network, and then usually after the deductible's been met, then they're doing like an 80-20, 70-30, something like that. And then you're usually having to meet your out of pocket before then they would cover 100% of that. So.
On the positive side, by the time a person needs day treatment or a higher level of care, the parents have already put out quite a bit, and you hope that starts early in the year so that they can put that all towards deductible, right, and get a lot more help later on. So that is one thing.
Your meeting has ended.